Assalamu alaikum dear doctors. In this video I am discussing a very important video stations. It frequently comes on exam and also history come. So first we'll watch the video, then I will discuss what type of question we are expecting from this video station. First description what I watch in this video, I can see a 15-year-old. She is an adolescent girl on hospital setting. She's body build is average and she is taking nebulization and there is fast breathing of the chest movement occur and someone counting the respiratory rate. It is a case of bronchial asthma. Sometimes bronchial asthma it most commonly on adolescent girl. So if it is already a diagnosed case, then we tell the DD of exacerbations. If not, then bronchial asthma and any chest conditions, viral induced wheeze. If his child, we can say multiple trigger wheeze, and also any chronic conditions that causes wheeze. If child present with wheeze, then we tell this. Like secondary to wheeze, chronic condition, these are cystic fibrosis, immunodeficiency, anatomical malformation, bronchiectasis, bronchiolitis obliterans. So our case is bronchial asthma. The DD of exacerbations are, I am telling, non-compliant to treatment, wrong technique, inappropriate dose, triggers are still there, wrong diagnosis and other types of allergies coexisted. Now what history we like to ask? The history we ask the onset, course and duration, what exacerbates and what relieves. Usually any triggers like exercise, food, psychological issue. Then frequency of the attack, need for reliever inhaler. Other allergies like eczema, allergic rhinoconjunctivitis, food allergy and anaphylaxis, growth and development, weight and height. Then family about the socio-economic status, home environment, other family members, vaccination status, school performance, daily activity. Then diary of the symptoms, PEFR, revised inhaler technique, home management plan, compliance to treatment and psychological. And also it's mild, moderate to severe. So we can ask that can he complete the sentences? Is there any sinused, pallor, silent chest? So these are also, anyone measure the saturations level, we can ask. Now what examination we do in bronchial asthma? First of all, I will do the airway breathing and circulation, oxygen saturations, hydration status, capillary refill time, consciousness level. Then chest examinations, I do the peak expiratory flow rate in older than 5 years. General examination for signs of steroid toxicity, Cushingoid features, I search, and weight and height, plot on growth chart. What investigation we do? So bronchial asthma, viral induced wheeze, all are mainly clinical diagnosis. I do the chest x-ray if the patient in life-threatening asthma, fever without focus and any concern regarding foreign body. Then I can do ABG, urea and electrolyte because hypokalemia after salbutamol infusion. I'm telling the management of asthma. If it is acute attack, so first we know that it is mild or moderate or severe or life-threatening. So mild to moderate, the criteria are normal vital signs, mild wheeze, speaking in complete sentences or feeding, SpO2 more than 92% in air, peak expiratory flow rate more than 50% in those age more than or equal 5 years. So these are the criteria telling mild to moderate. Then if it is on mild to moderate category, we give the salbutamol meter dose inhaler 2 to 10 puffs with a large volume spacer plus minus face mask. Then we give the oxygen if SpO2 less than 94% in air. Once daily oral prednisolone if on maintenance therapy, discuss with the respiratory consultant or nurse. And age less than 2 year equal maximum 10 mg once daily, age 2 to 5 year maximum 20 mg once daily, age more than 5 year maximum 30 mg once daily. Dose actually not needed. So mild to moderate criteria and the treatment is salbutamol meter dose inhaler 2 to 10 puffs via large volume spacer, oxygen giving if SpO2 less than 94% and oral prednisolone we are giving. Now reassess the every 15 to 30 minutes. Then condition improve. Discharge criteria meet. What are the discharge criteria? That is SpO2 more than or equal 94% in air, peak flow rate more than 75% or equal 75% predicted, and stable in 4-hour inhaled treatment. So after treatment 4-hour inhaled, these are the discharge criteria meet. I am telling the respiratory rate and heart rate according to age, that is less than 5 year, less than 40 breaths per minute and heart rate is less than 140 beats per minute. 5 to 12 year, respiratory rate is less than 30 breaths per minute where heart rate is less than 125 beats per minute. 12 to 18 year, respiratory rate is less than 25 breaths per minute where heart rate is less than 110 beats per minute. So also no there is tachycardia or no any tachypnea. So discharge criteria are SpO2 more than or equal 94% in air, no tachycardia, no tachypnea, peak flow rate is more than 75% predicted, and stable 4 hour. Then we discharge. Then discharge home, continue once daily oral prednisolone, complete a 3 to 5 days course, and review long-term asthma control plus treatment. Check inhaler technique, provide PEP, agree follow-up plan, and complete the respiratory discharge letter and discharge. Now I am going to the second row, that is severe asthma. So severe asthma, from the criteria we know that what are the criteria? That is too breathless to talk and feed. SpO2 less than 92% in air, use the accessory muscles, and the respiratory rate and heart rate is increased. Already I tell according to age, tachypnea, there is tachycardia, and peak flow is less than 50% predicted, more than 5 years of age. So these are the criteria of severe bronchial asthma. Then first I am giving oxygen via mask or nasal cannula. Then salbutamol meter dose inhaler 10 puffs via large volume spacer plus minus face mask. Then salbutamol nebulized driven by 6 to 8 liter per minute. If poor response, then give ipratropium bromide nebulized. And daily prednisolone for maintenance. If oral tablet not tolerated, give hydrocortisone via slow IV injections. So severe criteria I already tell. The management is oxygen via mask or nasal cannula. Then salbutamol meter dose inhaler 10 puffs via large volume spacer plus minus face mask, or salbutamol nebulized we can give. If poor response, we are adding ipratropium bromide. Condition improve, we are giving once daily oral prednisolones. And if prednisolone is not tolerated, we are giving IV hydrocortisone injection. If improving discharge criteria meet, then we are discharge criteria we know, and then discharge the home accordingly. But condition is not improved, then we will continue oxygen via mask, nasal cannula. We admit the child, continue oxygen given, nebulized salbutamol given, repeat ipratropium bromide. Okay. Now if not improving, it going to the life-threatening asthma. So what are the life-threatening asthma of a, the criteria are on history we will find, S is the ABC, there is cyanosis or pallor, silent chest, poor respiratory effort, altered consciousness, SpO2 less than 92% in air, there is exhausted, the person is peak expiratory flow rate is less than 30% in those age more than or equal 5 years. So this is the criteria of life-threatening asthma. And what we give in life-threatening asthma, first inform the on-call consultant, I will involve the my senior, I will admit PICU. Oxygen via mask or nasal cannula, then continuous salbutamol nebulized inhaler 5 to 8 liter per minute and oxygen, and ipratropium bromide nebulized I am giving, hydrocortisone IV giving. If signs of shock, then sodium chloride 0.9% 20 ml per kg IV bolus. So I am again telling life-threatening asthma criteria already tell. Management is I will inform my on-call consultant, admit the PICU, oxygen via mask or nasal cannula, continuous nebulized salbutamol I am giving, ipratropium bromide nebulized giving, hydrocortisone IV giving, and if shock features, then sodium chloride 0.9% 20 ml per kg IV bolus. Not improvement. If response, then according to discharge criteria meet and we will discharge, but no response. So continuous nebulized salbutamol, repeated ipratropium bromide. If poor response, give every 20 to 30 minutes for first 2 hours. After that, we are giving the last is salbutamol IV. Consider magnesium sulfate IV, blood gas and chest strain. In the last stage, we are continuously follow up the child, record the heart rate, record the respiratory rate every 10 minutes, continuous SpO2 and carbon dioxide monitoring, ECG monitoring, baseline urea and electrolyte monitoring. So this is all about mild, moderate, severe, life-threatening asthma management, which comes also on history. I am telling about the chronic asthma management, that is step up and step down management. So together I am telling both under 5 years and 5 to 12 years. So mild intermittent symptoms, that is under 5 years and 5 to 12 years, both we are starting with short-acting beta agonist. Okay. And after that, regular prevention therapy, under 5 years we are giving regular inhaled corticosteroid or leukotriene receptor antagonist if steroid cannot be used. So less than 5 years in short-acting beta agonist, we are adding regular inhaled corticosteroid or leukotriene receptor antagonist if steroid cannot be used. But 5 to 12 years with short-acting beta agonist, we are giving regular inhaled corticosteroid. Now, initial add-on therapy, next step. Among them, under 5 years, we are giving a nicotine receptor antagonist to corticosteroid, and 5 to 12 years, we are adding long-acting beta agonist in plus to inhaled corticosteroid. If no LABA response, stop the LABA and continue to the step 3. If improvement with LABA but insufficient control, continue to step 3. Okay. Additional add on the therapy, both under 5 years and 5 to 12 years, that is that increase the inhaled corticosteroid. Next step, consider adding nicotine receptor antagonist to therapy. But high dose therapies, next step, we are giving consider trial of increasing inhaled corticosteroid again, then addition to a fourth drug, example slow release of theophylline, and refer to specialist care. And the last step is continuous or frequent use of oral steroid. Use daily steroid tablet in lowest dose, providing adequate control. Maintain the medium dose inhaled corticosteroid. Consider other treatments to minimize use of steroid tablets and refer to specialist care. On the comment box, I will send this step up and step down management, both 5 years, less than 5 years, and 5 to 12 years. I'm telling about the asthma advice. Number 1, avoid the triggers like dust, mites, cold weather, pets, and smoking. Number 2, using your inhaler correctly. Number 3, diary of the symptoms and peak expiratory flow rate. Number 4, exercising regularly with caution of exercise-induced asthma. Number 5, eat healthy. Number 6, getting vaccinated, annual flu vaccine and pneumococcal vaccination. Number 7, on traveling, make sure you have enough medicine with you and keep your reliever inhaler easily accessible. Number 8, stick to your follow-up visits regularly. Number 9, always remember asthma action plan and call ambulance if you feel worse at any time and if in red zone or yellow zone and getting worse. So this is all about bronchial asthma stations questions. Thank you very much.